Post-streptococcal acute glomerulonephritis. Post means after streptococcus infection. Acute means acute, and chronic glomerulonephritis means inflammation of the kidney. Once upon a time, this entity was very common, with the but currently with the advent of the better treatment, better care throughout the globe, the antibiotic use, its prevalence is really decreased dramatically in West America and West Europe. They say it is almost non-existent, but in developing nations, low and low middle income country, it is still prevalent, and the aboriginal populations in some of the countries like Asia, Australia, New Zealand, and some of the even the developed nations like Pennsylvania of America, they have some aboriginal people who has this entity still to some extent. So what happens over here after throat infection, 1 to 2 weeks after throat infections, and 3 to 4 weeks after the skin infection, patients develop the antibody-mediated immune complex destruction of the kidney, inflammation of the kidney, leading to the hematuria, gross, microscopic, and little bit of proteinuria, but prominent hypertension and renal failure, acute kidney injury, azotemia, at times not may not be severe good amount of time, and edema. Your your patient can have hypertensive left ventricular failure and encephalopathy, as well as the other issues like the cyclothymia, acidosis, hyperkalemia, hyponatremia, etc. So these are the presentations, and this is the same. So how do you investigate the typical history? The C3 level low, azotate high, polymer leukocytosis, creatinine is a little bit high. It's around how much? In adolescent child, as I said earlier, it is a school age problem, 5 to 15 years. So they have normal creatinine how much? 0.7, 0.8, 6 something, but their creatinine goes up. They go up. It's around 0.1, 1 point something. 1.2, 1.5 something. There are a little bit of 40% cases. In this 60%, they do not have azotemia. So the creatinine and electrolytes, hyponatremia or normal potassium, for normal sodium, for hyperkalemia, acidosis, they are common. And the other C3 antibody markers like anti-DNSB, the rulo test, slide agglutination test, there can be done. And then NAPL antibody is a measure of the protectability here, and also is a measure of the specific for the streptococcal infection. So they can be done, and to exclude the other differential, like CTGP, you need to do at times the biopsy when the child has passed 3 months, even no remission of the disease. Then you have to think CTGP and other differences like the lead counts, the IJ vasculitis, and in female grown-up child, it is the lupus nephritis. So course of time, good amount of time, if the blood pressure, hypertension resolves by 2 weeks or so, rarely it goes beyond 6 weeks. And azotemia, the creatinine raised tissue, it goes by say 2 weeks or so. Oliguria, they go by 2 weeks. And usually everything is normalized by 3 months. If it doesn't, you have other diagnosis like your CTGP. So how to treat this child? They are the overload issues. So they have the renal impairment, acute inflamed glomerulus, so less amount of excretion, edema. So fluid overload is the principal issue. So treat with the diuretics. Furosemide is the best choice over here. 1 to 12 milligram per kg, oral or IV. Rheumatous patient, IV is nice. Go on giving it until you have the normal blood pressure. But a small amount of time, you do not have adequate control of BP. In those cases, you need to add something else. Maybe your calcium channel blockers, maybe that beta blocker if there is no heart failure. ARB and ACE inhibitor, they are not good choices over here because of your renal impairment. Finally, in 95% to 99% of cases, have very eventual recovery, very good outcome, and then only 1%, very rarely another 1% can have CKD progression.